Good morning and welcome to the Public Health and Minority Health Disparities Subcommittee. It is February 13th. We are getting started. We have a packed agenda today. We have 6 bills that we're going to talk about. And I'm going to try and get everyone out at a reasonable hour. So thank you all for being expedient in getting over here and getting logged in after our floor session. We are going to start with House Bill 153, medical records fees, attorneys representing patients. Erin, if you can walk us through the bill and the amendment.
Okay. House Bill 153 adds an attorney representing a patient to the list of individuals to whom a healthcare provider is prohibited from charging a fee for providing copies of a medical record that will be used for the purpose of filing a claim regarding or appealing a denial of Social Security disability income or Social Security benefits. There is an amendment that's being offered by Delegate Rosenberg, who's the bill sponsor. There's a reprint in your packet. If you look on page 2 of the bill on line 10, this clarifies that when the attorney must provide documentation that the attorney is representing the patient for the purposes of subparagraph 2 of this paragraph, which is referring to the disability claim or appeal.
Thank you very much. And just to clarify, Delegate Rosenberg, this amendment is to address the outstanding concern that was raised during the bill hearing. Is that correct?
That's exactly what I was going to say. Yes. Thank you, Madam Chair.
Thank you very much. Is there anyone who wants to be heard on this bill? All right. Can I have a motion on the amendment?
Move the amendment.
Second.
All right. It's been moved and seconded. Any discussion? All in favor of the amendment, say aye. Anyone opposed, go ahead and raise your virtual hand. All right. The amendment passes unanimously. If I can have a motion on the bill.
So move.
Second.
All right, it's been moved and seconded. All in favor, say aye. Any opposed? Go ahead and raise your virtual hand. Delegate Rosenberg, I assume that you're voting for your bill. And the bill passes unanimously.
Thank you.
Thank you. House Bill 461. This is Health State Advisory Council on Quality Care at the End of Life renaming. Erin, if you can walk us through the bill. I don't think there's no
amendments on this one.
Okay.
The bill renames the State Advisory Council on Quality Care at the End of Life to be the State Advisory Council on Serious Illness Care.
Thank you very much. Delegate Martinez, would you like to move your bill?
Yes, move favorable.
Can I get a second?
Second.
Any discussion? All right, all in favor of House Bill 461, say aye.
Aye.
Anyone opposed, go ahead and raise your virtual hand. The bill passes unanimously. Thank you, everyone. It's not going to be like this the whole time, but thank you. House Bill 189. This is the Maryland Medicaid Assistance Program, Provider Agencies and Personal Care Aids, Reimbursement and Wage Reports. This is the Home Care Workers Employment Act of 2024. We did hear this bill and we held it pending amendments. So Erin, if you can walk us through the bill and the amendments.
The bill is introduced would have required each provider agency by September 1st, 2025, and each year after to submit a report to the Department of Labor documenting the provider agency's average wage rate and highest and lowest wage rates for personal care aides. It also had a second part of the bill that required the Department of Health to conduct a certain rate comparison. There are substantial amendments. Do you want to talk about the amendments now?
Let's go ahead and talk about the amendments and then we'll open it up for anyone who wants to be heard on this bill, because I know a lot of work went into the original bill and then the amendments as well.
Okay, there's been a reprint provided that reflects some amendments that were worked on between the department and residential service agencies. The first part of the bill has been amended, so it would just apply to individuals who provide personal assistance services through a residential service agency. It strikes the language in the bill that said it would be for just those that are reimbursable through Medicaid. Then the entire second part of the bill, beginning on page 2, down through the bottom of page 4, that required MDH to do the rate analysis, which was why the bill had a big fiscal note. It was all about this rate analysis. So it cuts the fiscal implications of the bill. And then on page 4, after line 16, it instead requires that 180 days following the release of the final federal Ensuring Access to Medicaid Services rule, MDH must report to Senate Finance and HGO on an overview of the final rule and plans or steps that the department will take in order to operationalize the rule. And as part of the report, the department will include the process that the department will take to review wage reports of personal care aides and how this data will be used to review Medicaid reimbursement rates as outlined in the federal rule.
Thank you very much. Who would like to be heard on this bill? Let me open it up to Delegate Hill and Delegate Chisholm.
Yeah, I'm sorry, Aaron, you sent out a lot of
Sorry.
emails, and can you tell me which email? I mean,
The
I've tried to
first one, there was a
download
first email that had, no, wait, this would have come in.
like last week.
There was one right before subcommittee and there was one like an hour before subcommittee.
I've seen both of them. What's this bill? Is this 180? This is,
House Bill is 189.
okay, I'll look again. Thank you.
Delegate Chisholm?
Okay, I want to make sure I understood because Aaron said something that I want to make sure I got. So that before it was only applying to Medicaid, now it applies to all RSAs? Okay, and it says average wage rate for personal care, and then we got highest and lowest. Are they actually going to be looking at, let's say that you're an RSA and you have 100 employees, are they going to be providing like an ADP summary of every employee? This one makes 15, this one makes 25, or is it going to be of our whole 100 employees, we have one person that makes 15 and one person that makes 35? Or are they going to have the actual raw data of every single employee?
I would ask someone on the call how they intend to do it.
I was going to say, do we want to hear from the department since they helped with the amendments?
Yeah, and David, I don't know if you want to chime in here. I think, on this part, and then I can take the other piece if you want to do it that way.
Sounds great. Thank you so much. And thank you for that question. So the bill still only applies to Medicaid. It does not cover any privately funded home care at all. And not only is it just Medicaid, but it's only Medicaid under the Office of Long-Term Services and Support. So it's not DDA funded home care because our residential service agencies only provide care not through DDA. So just on that point, on the average wage rates and highest and lowest. So that the purpose of that is to get data that the state needs in order to determine what's an appropriate reimbursement rate. Can't do that without knowing what workers are being paid. So the average and the highest and the lowest shows the state what the sort of range is that workers are being paid. And then the state can use that. And actually, when the CMS rule comes down, all states are going to have that information because they're required to take it into account when setting appropriate Medicaid reimbursement rates. So that's what it is, average, highest, and lowest. And it just helps Maryland get a jump on what it's going to have to provide anyway when the CMS rule comes down.
Yeah, and Delegate Chisholm, thanks for the question, and David, thanks for that context. We were purposeful because part of the study that was included in the original legislation was a study on cost-based efforts, and because of this federal rule that's we expect to be finalized sometime here in the next few months, worked on looking at what the proposed was that would have the department needing to collect this wage information. And we've tried to align the components of that with what we think the department would need to get started on that federal rule. And then in substitute of the cost report, because the rule is so significant in terms of structure of payment, adequacy, and transparency about how this work gets set, we would be providing a report in terms of operationalizing the federal rule to the Senate and House as instructed by the amendment rather than the cost study at this moment in time.
Just so I can have a better understanding, when we're looking at this data set, I know we're only looking at Medicaid, RSA nows, and not DDA. We have an idea of how many RSAs that includes and the total number of employees?
Yeah, so similar on a previous legislation that we were talking about, we looked at Medicaid enrolled RSAs in Maryland, and that's about 920. If I remember correctly, Delegate Chisholm, I don't have, as part of OHCQ, they do a survey that looks at asking the difference between those workers that are employed as independent contractors versus employed individuals. I don't have that off the top of my head, but it's not a full representative of the 920, but there are 920 enrolled Medicaid RSAs in the state.
Okay, thank you very much.
You're welcome.
And Ms. Kaufman, did you want to add, because I know you were working actively with the department on these amendments as well.
Yeah, sorry about that. And I appreciate the question, because the amendments that you have before you inadvertently struck out the Medicaid, that it only applies to Medicaid. That is supposed to remain in. I think it's Amendment 3. We struck lines on page 2, 1 through 11. Those would need to stay in. That was just a mistake in trying to draft, but the intent was that it always just applied to Medicaid, because that's who the rates are under the purview of the department, the reimbursement rate. So I just wanted to clarify that, and I've let the council know as well.
Thank you so much. Delegate Hill.
Thank you. Thank you, Madam Chair. I think this is for David, but if not, are you sure that what you're asking for, that what you want to collect is the average and not the mode? In other words, if you've got high folks, it's going to be, the mode tells you what's the most common rate that's being paid.
Thank you, Delegate Hill. I think, to be honest, what advocates want is a report of each worker's pay rate to get the fullest possible information to the department when setting wage rates. The average was sort of a compromise. So I think, the more, speaking for myself and the workers' perspective, the more wage data that the state has, the better informed it is when setting wage rates. But what this is just sort of reflects the compromise that we've landed on. So I'm not sure, frankly, whether mean, median, or mode is really the most informative, to be honest with you. It's an interesting question. I hadn't considered it until you asked it, but it's a great question. But I think what this is sort of, I think, what everyone has landed on in terms of what they agree that they can support.
All right, I would just suggest, the amendment's I hope the amendment goes through, but I just suggest we be a little bit more thoughtful about, even in discussion with them. I think a lot of people think an average is one thing, as you know. And if you've got one person who's being paid 100 and everyone else is being paid 10, and everybody else is 3 people, that's a different number than if you ask what the most frequently pay is, and which is 10, right? So I just want to make sure we're there's no point in gathering data if it's not, actionable and of use. Thank you.
And Delegate Hill, I'm actually going to turn to Mr. Moran on that as well. The compromise language of the average, do we think that gets us where we need to be for the federal guidance that we're about to have?
Thank you, Chair. It's an interesting question. Thank you, Delegate Hill, for raising it. I think, David, this was a conversation that you had with industry on this particular piece. I believe it would give us the direction that we need in order to get a sense of wide. I think David's right, to really get to true cost base, which is what previous cost studies didn't do in the past. We cited the Hilltop report in 2018, which is to really get to granular level data. The more data you have, the better in terms of cost related to the providers, but it certainly would be more than we have right now to do cost-based studies.
Thank you. And I saw Alex Petukov unmute from Circle of Friends. Did you want to be heard on this bill?
No, not on this one. Thank you.
Okay. All right, thank you very much. Aaron, I think we might want to hold this bill just so we make sure that we've got the amendments as they are finalized. What is your thinking on that?
We can, I mean, the amount, it's easy to reinsert the language. It's not a difficult amendment.
Oh, okay. Then, if the subcommittee is comfortable, we can move the amendments with the understanding that we're going to, return the lines that were inadvertently struck. So, let me if I can get a motion on the amendments.
Move the amendments, Madam Chair.
Second.
All right, they've been moved in second. Any further discussion on the amendments? With the understanding that we're going to reinsert the language that clarifies that this is for Medicaid only. All right, all in favor, say aye.
Aye.
Any opposition? Go ahead and raise your hand. On the bill as amended, can I have a motion?
Move the bill as amended.
And can I get a
Second.
second? Thank you. Bill's been moved and seconded. Any further discussion? All in favor, say aye.
Aye.
Anyone opposed? Go ahead and raise your hand in the chat so we can record you correctly. All right, thank you. The bill passes unanimously. All right, that was 189. So we're going to move to House Bill 127. This is the Public Health Non-Occupational Post-Exposure Prophylaxis, the NPEP Standing Order Program Establishment. Aaron, if you can talk us through the bill and the amendments.
Okay, this is a departmental bill. It establishes the non-occupational post-exposure prophylaxis standing order program. Under the program, the program would authorize a licensed pharmacist to dispense NPEP under specified circumstances. The Department of Health will administer the program, collect fees, establish guidelines for conducting patient education and training, and will collect and report data on the program. There are amendments that have been provided through a reprint. These were worked on with the department and MedChi and MCASA. The amendments strike references to private or public entity from the bill. So the bill would only apply to pharmacists. It also strikes references under the definition of standing order to healthcare providers. On page 3 of the bill, it strikes the authority of the program to authorize a licensed healthcare provider with prescribing authority to prescribe and dispense NPEP through a standing order. It also clarifies, so the department under the bill is authorized to collect fees necessary for the administration of the program, but it clarifies that the department will not collect fees if the patient qualifies for NPEP through the program for preventing HIV infection for rape victims that is outlined in the criminal procedure article. It also, whenever CDC guidance is referenced, that the program would use the most recent CDC guidelines, and that's throughout the bill. It also provides on page 4 of the reprint that when a pharmacist who is registered with the program dispenses NPEP, that the pharmacist would determine whether the patient meets clinical criteria consistent with the most CDC guidelines, including the identification of any contraindicated medications, and if applicable, exposure as a result of alleged rape or sexual offense or alleged child abuse. There's also a provision in the bill that the department, when a pharmacist is dispensing NPEP, that the pharmacist would determine whether the patient has a primary care provider, and if the patient does not have a primary care provider, the amendments provide that the pharmacist would provide the patient with a list of local primary care providers and clinics, and that list would be provided by the department to the pharmacist. Then on page 5 of the bill is introduced authorized licensed healthcare provider with prescribing authority who is registered with the program to delegate the dispensing of NPEP under a standing order to an employee or volunteer of an authorized private or public entity. That is stricken from the bill. The bill is introduced also authorized any licensed healthcare provider who has dispensing authority to dispense NPEP to an individual, and that has been stricken from the bill as well. So it just applies to pharmacists now.
So I want to hear from MedChi and from MCASA, because I know you had outstanding concerns at the bill hearing. Do these amendments address your concerns? Let me start with MedChi.
Thank you very much. We had a really good productive meeting with the department and the pharmacists and MCASA and everyone, and we are fine with the amendments as described by Ms. Hopwood.
Thank you so much, Ms. Casemeyer. Ms. Jessic from MCASA?
Yes, thank you. So we are good with the amendments. We feel that they do address the issue of the sexual assault reimbursement units program and help ensuring that anyone identified as a survivor of sexual assault will not be charged for this medication per that program. We do have some remaining concerns about how this will work. It seems like the idea is to keep this in regulations and protocol, including like sexual assault survivors being referred to a sexual assault forensic exam. So when they receive this NPEP or approach a pharmacist, access to an advocate, and those items. So we are under the impression that we will work with the department on the protocol and regulations related to that. I do think there are some remaining concerns from providers related to things like the required lab testing that should be completed when starting NPEP to make sure renal function, liver function, hepatitis C, HIV negative before starting that procedure. One thing in particular, I think MCASA identified is, if someone's pregnant, they should not be starting this medication, or it would be a different regimen. So oftentimes individuals may not know they're pregnant when they're going to receive this medication. So how are these things going to be addressed? And I think Jane Cranky from the Maryland Hospital Association is also on, and I know she's been working with some providers who have those same concerns as well.
All right, let me turn to the department, and then Ms. Cranky, if you want to be heard as well. So,
I don't know if Dr. DiMartino has specific responses to some of these concerns. I will say that I think just from our perspective, I think we had thought we had gotten to a place where we were comfortable with dealing with most of these regulations later. We did receive, I think, some questions that we responded to from MCASA and MHA in the past, I don't know, keep me honest, Sarah, day or so.
I didn't receive them Sunday, and we did try to respond yesterday evening, just clarifying that we do feel like many of these concerns would be better addressed in protocol and regulation, and reinforcing our commitment to work with MCASA and MHA on developing those protocols and regulations, and potentially the trainings themselves to ensure that they adequately reflect some of these more sensitive case-specific inquiries.
But Dr. DiMartino, I don't know if you have other information to add.
No, I think we were attempting to cover everything by ensuring that in statute we are addressing that we will be utilizing current CDC guidelines and understanding that those are very thorough, very rigorous, and not including all aspects of that in statute, but ensuring that we're working with all of our stakeholders through the implementation, the development of the protocol, training both the department and the registered pharmacists, particularly around some of the more sensitive cases that we're sure to encounter, was the way we would like to move forward.
thank you, Dr. Martino. I'm going to turn to Ms. Cranky and then to Delegate Hill.
Great, thank you. And we do want to thank the department. They've been fantastic in receiving our feedback. I think maybe just adding some clarification in the bill where it says the department shall adopt regulations, just including provision that says that will include special populations like children and sexual assault survivors. I think just having that assurance that we know that the board or the department will address this, but having the assurance that that'll be a specific focus in regulation, I think would help, address some of our concerns. So thank you.
Thank you. Delegate Hill.
Thank you, Madam Chair, and thank all of you for the work on this. I think it's important. But I would appreciate maybe Dr. DiMartino, if you could walk me through what this would look like for someone who presents to a pharmacist as opposed to the hospital or through MCASA and, is saying, I've had this encounter and I'd like to take the prophylaxis. So in terms of they get a survey form. I'm not sure how we're screening for unknown kidney or liver disease, and what happens. And you also mentioned that some people would be rejected if they don't have a primary care. So if you could explain how this would work. I know regulations are coming, but I need to see what we're really talking about here.
Sure. And of course, I think there's significant stakeholders that need to be engaged as we develop the full protocol. We do have a draft protocol that is based on the CDC guidelines. We clearly want to vet that to ensure that we are covering all aspects that you've mentioned. The intent is that this program is really just addressing the access piece to ensure that the drugs are available within that 72-hour window. The department's role in this, again, is really ensuring that those connections are made, addressing both sort of practice management for pharmacists and ensuring that that follow-up does not become their administrative burden. So it really is about getting the drugs to the individual who runs through the protocol and qualifies to receive NPEP, and then really making that connection as soon as possible. And internally, we've been working with a less than 24-hour response time to ensure that all of the connections to care are made as soon as possible. So we're really creating just an access place where we're opening up more avenues for access to NPEP than just emergency rooms.
So that didn't, again, I mean, quick access, there are people who show up at minute clinics and urgent care places and frequently show up there because they can be seen quickly, and I don't hear about a backlog there. So again, we're introducing pharmacists, and I'm not clear what happens clinically. And I understand protocols, but what happens clinically, that's different from, someone self saying, I need this medication, and asking their friend Bob to score for them so they can get the medication and start themselves on it. What is happening clinically so that the pharmacist who's acting in a clinical role is making the right decision about who gets this medication and who should be on this protocol, as opposed to saying to them, go to the urgent care place and get access. You need to get it within 72 hours.
Yeah, so the clinical piece would really not be done by the pharmacist. It would be done with a follow-up connection to that clinical care.
Thank you.
So I'm going to go ahead and take the questions so that we have the conversation, but just for the members, we are going to hold this bill because it sounds like we still have outstanding questions, but I want to get them all on record so that we have the stakeholders have time to work on all of the outstanding concerns. So let me go to Delegate Martinez, and then we'll go to Ms. Horton.
Thank you, Madam Chair. And this is for Dr. DiMartino. So right now in Maryland, if, let's say, I was to have an exposure or potential exposure and needed NPEP, could I just go to a minute clinic or urgent care and self-identify as someone that was pre-exposed or potentially exposed and receive the medication?
You can. What we have heard from our stakeholders, from our community members who have attempted to do so, is that it is not as easy as one would imagine, and they're actually often denied the medication. I have personally counseled individuals attempting to receive NPEP or be prescribed NPEP. It is not something that many providers are aware of, be comfortable with, particularly when we're talking about a non-occupational exposure. So what we're really trying to do here is identify welcoming environments through specific pharmacists who are registered with the program and are addressing a specific protocol to address any clinical concerns as much as possible up front. But it really is about closing that 72-hour window to have another avenue of identified access points where individuals experiencing that moment of concern will be sure they are walking into a welcoming environment where their issues are understood and they are being responded to appropriately.
So just so I'm clear, and for our members, this is simply establishing a program that, for layman's terms, creates like a green book kind of guide to acceptable providers and practitioners who will be welcoming of folks like myself that are within the LGBTQ community or other marginalized communities who right now are having roadblocks put up to receiving care.
Yes, and also open at 2 a.m. Or 4 a.m. and not experiencing a 4 to 12-hour wait.
Thank you.
Okay, given that that we do still have a lot of outstanding questions, I'm going to go a little rapid fire because we do have 2 more bills, but I want to make sure that we get all of the questions out so that we've got some time to work on the answers. So let me go to Ms. Horton and then Ms. Kiesmeyer and then Delegate Chisholm.
Hi, thank you. I just wanted to refer back to Delegate Hill's comment about the clinical process. So I have not seen the protocols, the draft that the department has put together, but we have precedent in the state for these types of protocols and screening processes like we did with the contraceptive prescribing. So within the protocols and the guidelines, it's based on the CDC guidelines. There's decision trees, decision matrices. They're all evidence-based protocols, so to speak. And so there's steps to go through that process. And I think that we can all work together to make sure that they're appropriate. When we did contraceptive prescribing, all the stakeholders were involved in that process and finalizing those regulations. So I feel confident that we can get something that is that has a comfort level with the pharmacists as well as with the provider community and the stakeholders of whom we're trying to serve. So we're happy with the bill with the amendments that have been put forth so far. We don't want to put too many additional items in the text. Because when we start getting too detailed in the statute, that can hamper us when future changes need to be made within regulations or within protocols. So we'd like to work those things out on the next step.
Thank you, Ms. Horton. Ms. Kiesmeyer.
Yes, thank you. And again, a bit related to Delegate Hill's question and concern, because we had a lot of concerns with this bill when it first came in. But what we have understood, and it is in the bill, and again, it's relative to the protocols, but also the continued clinical intervention and follow-up is the most critical piece of this is that at the time the pharmacist is dispensing, they have to refer that person. It's not only the primary care issue that's in the bill, they actually have to call and refer to a disease intervention specialist out of MDH. And they have a whole staff of folks that will be immediately in touch with the person who's receiving the MPEP to assist and advise and work with them to make sure that they're getting the services they need, they're connecting up with what they need, that everything was working correctly. That provided a great deal of comfort, assurance that they wouldn't just be able to walk in, pharmacy shop, make up their answers, and then disappear into the woodwork. There'll be a disease intervention specialist that they're connected with. And the other thing is, this doesn't mean that all pharmacists can do this. They have to actually be a program participant. So there may or may not be that many pharmacies that choose to want to have this kind of a protocol service available. Probably most likely in communities where there's more likely access issues than necessarily across the board. It's not an expansion of authority for all pharmacists and all pharmacies.
So I have to thank everyone for their explanation. Madam Chair, I'm open to appreciate any offline conversations.
And I was actually just going to say, Delegate Dr. Hill, if you could connect with Dr. Martino and have those offline conversations and see if we can find a comfort level. But I really appreciate you bringing up your concerns in the subcommittee so that we can get them addressed. Delegate Chisholm.
Thank you, Madam Chair, and I'll make this fast. My simple question is, do we need legislation? This seems like it's all protocol stuff. Is this more, I hear about roadblocks, but it sounds to me like we can already accomplish all these things without legislation. And is it more education and community outreach to, I guess, reassure people that are prescribing this drug that they can do it? Because it sounds to me like they can already do this. I know you want to put in some backstops now and set some new protocols, but I don't know if do we need legislation for that?
Well, and I'm gonna ask the department to answer that, but I will say that this would be the first time that the department has asked for a bill if we didn't need it. So, Department of Health, if you can speak to why we need the bill, it's a great question.
I can defer to Dr. DiMartino as well, but my understanding is one of the key things that this does is because it expands this to pharmacists, it adds an additional group that can do the provide the prescription, which are not currently able to provide NPEP at this time.
So we have to put it into statute in order to expand to pharmacists. Is that correct?
It is that, and this is also a new function for the department from the perspective of disease intervention. So generally, the type of services that we have been discussing are not provided until a diagnosis. So we are expanding the services that we now provide to individuals who are newly diagnosed or who are diagnosed with syphilis, gonorrhea, or chlamydia. We are providing those to individuals who would be accessing this program pre-diagnosis, essentially. So that is a change in scope for the department as well, is actually being able to interact with constituents, provide this level of constituent service before they are diagnosed with HIV or an STI.
And just for our clarification, and that's because of the very tight window of opportunity between the exposure and the protocol.
Yes, it's the tight window creating that access point with pharmacists, but it is also allowing the department to provide that level of linkage to care, treatment adherence, and ongoing services.
Thank you. Does that answer your question, Delegate Chisholm?
Somewhat, but I'm still a little confused on the outreach part because the department has the ability to do a lot of this outreach. I understand the goal, and I'm with the goal. I just am a little confused on the legality of it, but I'm good.
All right, thank you. I'm going to take one more question from Ms. Jessic. Ms. Horton, I'm going to ask that that you talk with us offline because I want to make sure that we are addressing. We've got a couple more bills today, and I want to leave time for folks to get a break before committee.
Thank you, Madam Chair. I just wanted to note that we at MCASA understand the access issues in that tight turnaround window. We're not opposed to this bill, and I apologize for bringing up these continued questions. But I do want to note that I think I heard a couple times someone said that they met with MCASA, and MCASA has not been part of any meetings to date, to my knowledge. We have had great back and forth through emails, but it would be excellent, if you have any future meetings to loop us in, and maybe we could be on the same page before any further discussion with the committee.
Okay, thank you very much. Noted. I'm sorry, Ms. Horton, was there another outstanding concern or just context to the conversation?
Yes, it was just quickly that legislation would be required because the standing order that this bill provides basically serves as a prescription for people to come into the pharmacy. Without it, the pharmacist would not be able to dispense it unless a person went somewhere and got a prescription.
Thank you. Thank you so much for that clarification. I think that I'm seeing Delegate Chisholm that solved the mystery for us. As I said, we're going to hold this bill because we still have some outstanding concerns to address. But thank you very much for this conversation. I think it was incredibly informative and helpful to the members. We're going to move to House Bill 177. This is hospitals' care of infants after discharge. Erin, if you can walk us through the bill, and this one, we do have amendments as well.
Yes. So the bill would require a hospital prior to discharge to provide oral and written educational materials to an infant's parent or legal guardian on how to provide a safe sleep environment and to avoid shaken baby syndrome. Before discharging an infant, a hospital must inquire as to whether the parent or legal guardian is able to provide the infant with a safe sleep environment and a bassinet crib or portable crib, and inform the parent or legal guardian of the importance of ensuring the infant has a safe sleep environment. There is a reprint of the bill that has been provided, and there's also a separate amendment that I'll refer to along with the reprint. So the singular amendment just clarifies that these materials would only have to be provided after the birth of an infant, so a one-time. So say the infant had to go into the hospital later on another time, the hospital wouldn't have to provide these safe sleep environment instructions. It's only after that initial discharge, after the birth of the infant. The amendments also strike language in the bill. If you look on page 2, the bill is introduced, required the hospital to provide each parent or legal guardian with a standardized form that was in clear and simple language to be signed by the parent or legal guardian that confirms that they understand the instructions. That's stricken from the bill. And then there is new reporting language, or not reporting language, but new language at the bottom of page 2, requiring that on or before January 1st, 2025, each hospital must establish a process for providing each parent or legal guardian with oral and written educational resources and the information that's described in the bill. And then for a parent or legal guardian to confirm the receipt of the educational resources and to maintain the records of confirmations that were made under the bill.
Thank you very much. And is there anyone who wants to be heard on this bill? I know that there was favorable with amendment from the Hospital Association and also from the Department of Health. Do these amendments address those outstanding concerns?
I think that while MDH felt that many of these amendments were good, that the only one that we wanted to potentially add and flag was a connection between the hospital connecting the patient and the local health department, as many of these local health departments have many safe sleep resources that we feel would be strong and important addition. I'm going to pause here and see if Dr. Kalyana would like to add anything. That was I think our flag that we had in our suggested testimony with amendments.
Dr. Kalyana?
No, I think Ms. Kisser summarized it well.
Thank you so much. All right, I have a hand from Delegate Hill.
Here we go. Thank you. Yes. 2 questions. Erin, you said that it's clear that this is at the time of a newborn's first discharge, not a readmission. I'm reading the reprint and I don't see where that clarifies that. And the second question, is there any appetite for also requiring people attending a home birth, be it a nurse midwife, whatever, attending a home birth, to be sure that within some period of time, the families are provided with the same information. So 2 questions.
I can answer the first question. It was a separate amendment. You got one with a reprint and one that was a separate, and that's where it clarifies.
Okay.
That would be after the birth. And
Thank
the
you.
second question, I think, is a question for the committee.
And
The
Delegate Hill.
sponsor's here, right?
Yep.
Yes, I'm here. There was never any discussion about home births.
Is there any objection to requiring that, or would that be problematic for the bill at this early stage of session?
I would say this as the sponsor, and then I welcome all of the stakeholders to chime in. So as the sponsor, having worked with the health department in Baltimore City, the state health department and the hospital association since 2019, and it's taken us this long to accomplish this level of consensus, I think that what we've got before us is a bill that will go a long way to saving lives of newborns. And I'd be very content to move forward with the bill before us and then consider the question of home births in another bill. And that's just my perspective. And I would ask these other stakeholders to chime in, please.
I see a hand from Pam Casemeyer, from Ms. Casemeyer and Ms. Cranky.
Yes, I would agree with, no. I would agree with Delegate Lewis, and it isn't that our clients aren't concerned about figuring out how to put a lot of these protections into the home birth framework too. But I think that's a whole different kind of conversation and a whole different set of stakeholders. And this is been a priority for the AAP and others for quite some time. Safe sleep issues are very important. So I would leave it as it is, as she said, and we can grapple with that at another time.
Ms. Cranky?
Sure. And just to kind of go off of what Pam was saying, one goal of ours too is to think about the whole care continuum and how we can get the same resources across. So maybe when we're having those conversations, home birth can be part of that discussion, because I think it's a good point. There is a rise in home births, but we have put a lot of work into this bill and amendments, but open to discussions in the future. I did have a question on the Department of Health amendment, because I'm not as familiar with it. Is it a referral to a local health department at discharge, or is it just taking resources from the local health department on safe sleep? It'd be good to have clarification on what their amendment does.
And Madam Chair, if I may, and thank you, Jane, for your question. If we may first address Delegate Hill's question, and then definitely come back to the clarification on the MDH amendment. So
Look, I've got my answer. I got my answer.
Is that good enough?
Oh,
Madam
yeah,
Chair,
I wanted, that was the question. That was my concern. I think it's important to look at, but didn't want to derail the bill. So thank you.
Thank you, Delegate Hill. And maybe that's a bill that you and Delegate Lewis can work on using this as the framework.
Well, hopefully I won't be here. Thank you.
Very valid point. Go ahead to the department.
And again, I'll defer to Dr. Kalyanaraman or Dr. Chu if I state this inaccurately, but I believe our goal would be as part of the process of receiving information on resources, that there's an actual connection with the local health department, which has the ability to, in addition to providing information, connect patients with resources to actually receive safe sleep equipment if necessary, things like that. And I'm going to pause here.
And I see Ms. Shu has unmuted.
Yes, thank you, Sarah. And that is absolutely correct. It's both the information and then the actual resources, whether that's a portable crib or a bassinet.
Thank you very much. Ms. Whitten.
Thank you, Madam Chair and committee members. Here supporting MHA and the group that worked diligently on this. So just, I think for clarification, because this is new information, the new amendments coming to us. I think from the hospital's perspective, obviously we want to make sure we've got all the resources for parents and caregivers and guardians to be able to access those resources, but it might be a little bit of a nuance between ensuring that they have the information to follow up to access those resources versus a direct referral. And that's where it's a little bit unclear to me exactly what this amendment is proposing, because as you can imagine, that's a different process for discharge. So I just want to be mindful that we're sort of thinking through the mechanics of what the department's asking.
Okay, and I'm going to actually turn to our committee counsel for clarification based on the amended language and what they exactly do.
The MDH amendments are not part of the
Oh, they're not part of our.
No.
Okay, so then it sounds like we still have work to do on this bill.
Madam Chair?
Yes, yes.
May I?
Lewis.
So, unless I missed something, I'm only, and it's entirely possible, I'm only now aware of the Department of Health's proposed amendment that was mentioned. And I'll be honest, I thought we had, and so if I may just sort of, I'm processing because I hadn't incorporated this into my understanding of what we were all trying to accomplish. And my understanding was that having agreed that the Department of Health already provides a listing of resources on its website, Safe Sleep resources on its website, and that the act of giving information at the time of discharge, which will direct new parents and guardians to the MDH website, my understanding was that we had agreed that that was sufficient for this time. And again, I'm looking at the timeline of 2019 until today, when there's so many lives that could be saved by simply applying the steps we've agreed to, that we have all agreed to already. I am reluctant to continually adding another step to the process. So as a sponsor, I'm just sharing my perspective. I think we have a good enough operationalization of safe sleep education. And I'm reluctant to add yet another step, yet another requirement without clear rationale for how that would move us forward. Again, 2019 until today, I think we have a good enough bill, and I'd love to keep looking at it as the bill is implemented and we learn from it. There's already a process for child fatality review that we should continue to tend to, keep paying attention to, and iteratively improve our processes. But that's my reaction. Thank you.
And I appreciate that. And I don't disagree with you. I am going to hold this bill for this week because I think that's an important conversation to have with the department, and especially if we had an understanding that we thought we were there. So I'm going to go ahead and hold this bill so we can have those conversations offline. And we have the amendments that have been proposed. This is the first, as I'm understanding, that we're hearing about additional proposals. So I'm going to ask that we make sure that that we have everything, everything that we should have. Yes, Delegate Hill.
Madam Chair, may I move the two amendments that we discussed today so that if there's an additional amendment from the Health Department, we can add it on at the next meeting?
That is a great idea, Delegate Hill. You can move the amendments. Do I have a second?
Second.
All right, amendments have been moved and seconded. All in favor, say aye.
Aye.
Anyone opposed? So we have moved these amendments unanimously. We're going to hold the bill. We're going to hold the vote on the bill. And I'm hoping that the discussion next week is we don't need any more amendments. We have an understanding because we've had that conversation. So thank you to our members for your patience and for making sure that we fully understand the bill and the implementation. And I'm going to ask the department to speak with the bill sponsor, very, very quickly. We have one last bill today, and it's 10 after. So we will spend a few minutes on this bill, but it's okay if we're not fully comfortable. This is House Bill 51. This is the Maryland Pediatric Cancer Fund modifications. Aaron, if you can walk us through the bill and the amendments. Yes.
Yes, there are amendments.
Yes, there are amendments.
The bill would limit the authorized uses of the Maryland Pediatric Cancer Fund to providing grants to eligible applicants to conduct pediatric cancer research only. Currently, these funds can be used to provide grants for pediatric cancer prevention and treatment, and the bill repeals that authority. There is an amendment. There's a reprint drawn up to the Senate crossfile that was provided, and this is sponsored by Delegate Rosenberg that would authorize the Secretary of Health to distribute not more than 5% of the fund, and that's current law, and to a promotional account that it would be allocated to a Maryland-based American childhood cancer organization. And the amendment also would establish a commission that would oversee the competitive grant review process.
Thank you. And as a reminder to the members, this bill came from the fact that that the funds that were allocated for prevention and treatment were inadequate and were duplicative. But that it was draining funds from cancer research. Delegate Rosenberg, is there anything you would like to add?
I think you've described it well, and as counsel in describing the amendments. So I'm not aware of any opposition.
All right. Thank you, Delegate Rosenberg. Delegate Hill.
Okay, thank you. Sorry. Delegate Rosenberg, this, I just want to know, do we have more than one state-based agencies that do this, or this language particular to a particular state-based? I'm trying to see the language. The thing that talks about a state-based cancer, childhood cancer organization. How many state-based, roughly, childhood cancer organizations do we have? Or is there only one and this is directing money to that one?
Well, Ms. Huffman would know better than I, but I believe that hers is the only one, to my knowledge.
Ms. Huffman, do you want to go ahead and respond?
Thank you. Yes, we're the only ones that are doing this in Maryland and across the US. And we're a national organization, but we're based in Maryland.
Okay. And so what would happen, Delegate, if a year from now, another organization, would it still get routed? Is this competitive, or it's just in statute now that this organization in perpetuity until we act otherwise will be getting this funding?
Well, it says to a state-based childhood. So my understanding would be that if there were to be another entity, they would be eligible. That additional entity would be eligible, yes.
All right, thank you.
And I'm seeing Ms. Hopwood nodding her head as well.
That's correct. You have to draft it so more people could enter the class, and that's how it's drafted.
Thank you. Can I have a motion on the amendments?
Move the bill as amended.
I think we have to vote the amendments first.
Motion to move the amendments.
That's right.
Second.
All right. All in favor of the amendments, say aye. Any opposed? Go ahead and raise your hand in the chat. All right, Delegate White Holland, do you want to move the bill? As
Yes,
amended?
no, move the bill as amended.
Do we have a
Second.
second? All right, it's been moved and seconded. All in favor, say aye. Anyone opposed? All right, thank you very much. The bill passes unanimously. So we have two bills that we are holding. It's still early in the process, but I want to make sure that that our stakeholders come in ready to move these bills next week. Because we've got some work to do during the week, but make sure that you are setting up those meetings when we adjourn. And with that, can we get, I'm sorry.
Can I just make one note for House Bill 51? I'm gonna have to run it by appropriations just because now there's a commission added and just to verify the cost.
Okay,
We have
okay.
100,000
So we'll
threshold.
hold off on putting it on the vote list until we've got.
Yeah, I'll do that today.
Okay, perfect. Any other outstanding concerns? All right, can I get a motion to adjourn?
Move to adjourn.
All right, it's been moved and seconded. We are adjourned. I will see you all at 1 o'clock. Thank you so much for being very efficient.